Why private equity is killing your emergency room, and how they hide the bill. Sarah walked into Metro General at 2 a.m. with chest pain. In-network hospital, EKG, chest x-ray, for troponin 4 hours. 2 weeks later, $18,904. The hospital charged $6,237. After coding adjustments, a facility fee she'd never heard of, and an ER doctor employed by a Blackstone-owned group that was out of network, the total exploded. She thought insurance protected her. It didn't. That's not a one-off, it's the playbook. 3 levers do the damage: coding, upshifts, facility levels, and outsourced staffing. When private equity takes your ER, bills spike, care thins, and you fund their return, unless you know the counters. How private equity got inside your ER, the playbook entry. Here's what actually happens inside your emergency room. Most people assume the hospital employs the ER doctor. Increasingly, it doesn't. The badge might say City Hospital, but the paycheck comes from a national staffing company, names you rarely notice. M-Care under Envision, backed by KKR before Envision's 2023 bankruptcy, or Team Health under Blackstone. The firm supplies clinicians, hits throughput targets, and optimizes revenue. The hospital gets predictable coverage without HR headaches. You get a separate professional bill, and amaze. The wedge was surprise billing. For years, these groups kept ER clinicians out of network even when the hospital was in network. In an emergency, you have no choice. Insurers faced a pay-up-or-punish dilemma. Yale-affiliated researchers found that when M-Care entered a hospital, out-of-network billing and total spending spiked. That wasn't random, it was leverage. And leverage is the engine of this model. Step 1 is the roll-up. By regional ER groups, centralized scheduling, credentialing, and billing, and standardized contracts. Overnight, negotiating power concentrates without owning a single hospital. If a payer resists higher rates, the group credibly threatens to walk or stay out of network. Before 2022, patients got balance billed. After the No Surprises Act, the fight moved to arbitration, still a higher floor than many in-network deals. These deals are built on debt. A private equity fund buys the platform with borrowed money and loads that debt onto the operating company. Debt is a predator. It doesn't care if you get better, only that cash flow rises now. So the playbook kicks in: tighten staffing grids, raise RVU targets, shift more visits to mid-levels, and weaponize documentation. Templates nudge clinicians to higher evaluation and management levels. Longer histories, broader differentials, high-risk phrasing. Individually defensible, systemically inflationary. A clinician's voice makes it plain. An ER physician in Arizona told me, "We used to ask, what does this patient need? Now it's, what does the template require? If my RVUs per hour slip, I get coached. CT to be safe is safer for me, even when the probability's tiny. I'm not proud of that. I'm tired." That fatigue shows up on your bill and in your care. Regulatory arbitrage keeps the margin alive. Before 2022, out-of-network shock bills were the weapon. After the No Surprises Act, providers and insurers battle in the independent dispute resolution arena. Early analyses show awards often clear above median in-network rates, and the administrative churn raises system costs that land in your premiums. Meanwhile, the facility fee, charged by the hospital for the room, monitors, nursing, and overhead, sits outside those NSA guardrails. Level that up with the right boxes checked: continuous monitoring for meds, nursing intensity, and a short stay becomes a high-resource encounter on paper. Make it concrete. A hospital signs with a national group. The MSO installs documentation prompts. Persistent pain? Multiple systems reviewed. High-risk differential? Check, check, check. Hello, level 5E/M. The facility assigns an ER level based on resources used. A monitored bed, a couple of 4 meds, repeat vitals, and you're bumped. Imaging protocols lean towards CT to rule out because it's billable and defensible. 1 visit, 2 owners, 3 bills, 4 figures. Patients think the hospital is directing this. Often, it's the management company setting revenue targets, the billing vendor tuning edits, and distant owners enforcing a 3 to 7 year return timeline. Rural and safety net hospitals, squeezed by labor and payer mix, accept promises of revenue lift. That lift comes from somewhere. You, your employer's plan, and next year's premiums. Local dominance amplifies it. When a staffing firm covers most ERs in a metro, insurers can't steer to alternatives. If negotiations stall, The group goes out of network and leans on emergency must-pay dynamics or post-NSA, the arbitration floor. Either way, the price floor rises. You don't see contract brinkmanship. You see higher payroll deductions and deductibles. Debt pressure also shapes the shift. Fewer attending physicians per shift, more nurse practitioners or physician assistants running protocols, and dashboards tracking door-to-dock and disposition times. Length of stay becomes a hammer. Treat the symptom, discharge early, and avoid admissions that invite denials. Bounce-backs rise. Clinicians burn out. Good people leave. Locums fill gaps at higher cost. Continuity vanishes. A microstory from the floor. A charge nurse in Ohio told me, "We boarded patients for 18 hours last week because inpatient beds were tight. Hallway care isn't care. A kid with belly pain went home at midnight to clear a metric, came back septic at 6 a.m. We saved him. That doesn't show on a quarterly slide. The spreadsheet did fine. The family didn't. Once you see who writes the bill, you can defend against it. Ask at intake who employs the ER clinician and whether they're in network. Document legal names. Photograph consent screens. If someone asks for post-stabilization out-of-network consent, decline and request in-network care or have unavailability noted. After discharge, request itemization with CPT/HCPCS and the hospital's ER-level policy, plus the clinician note and build E/M code. If an emergency professional claim processed out of network, push for reprocessing under federal protections and log the reference number. Entry is just step one. The money machine runs on leverage, loopholes, and speed. Next, we'll flip on the work lights and walk the 7 profit levers line by line so you can spot, document, and knock each one down. The 7 profit levers that inflate your bill. Let me show you the 7 switches they flip to turn a routine visit into a revenue event. You won't see these on a wall, but you will see them on your explanation of benefits, and you'll feel them in next year's premiums. Lever 1, the out-of-network ambush. Most people think, the hospital is in network, so I'm safe. Not necessarily. The ER physician group can be out of network inside that in-network hospital. Before the No Surprises Act, that meant balance bills. After 2022, the fight moved into arbitration, where awards often land above typical in-network rates. Either way, out-of-network status becomes leverage. A Phoenix dad DM'd me. In-network hospital, out-of-network ER doc, $1,940, professional claim fixed only after he cited emergency protections and got a reprocess reference number. The bill didn't vanish. The premium pressure moved upstream. Here's your counter. At intake, anchor consent. I consent to emergency care. I don't consent to non-emergency out-of-network services. Log the clinician group's legal name. If your EOB shows an emergency professional claim processed out of network, call and request reprocessing under federal protections. Get the reference number. Lever 2, facility fees unbundled. The hospital charges a separate facility fee for the room, monitors, supplies, and nursing, tiered by emergency department level. Those levels creep when boxes are checked. Continuous monitoring for meds, nursing intensity. A 45-minute visit in a basic bed becomes a high-resource encounter on paper. A teacher in Denver sent me her EOB. Level 5 facility for nausea and fluids, professional level 3. We requested the hospital's leveling policy, showed criteria weren't met, and they downcoded to level 3. Her out-of-pocket dropped 62%. The care didn't change. The paperwork did. Your move, request itemization plus the ER level policy. Compare documented resources, monitoring hours, for meds, nursing intensity, to the assigned level. Ask for a level review if the boxes don't match the chart. Lever 3, coding upshifts. Documentation templates nudge clinicians to higher evaluation and management levels. Expand the review of systems. Broaden the differential, use high-risk phrasing. Individually defensible, systemically inflationary. An ERPA told me, if I don't document extensive, the edit flags me. So I document it. A sprain becomes polysystem review with high-risk differential. That flip adds $100 to $250 to the professional claim and resets benchmarks for arbitration. Your counter, request the visit note and build E/M code from the physician group. If the documentation doesn't support the level, ask your insurer for a clinical review anchored to medical necessity and resource use. Lever 4, ancillary add-ons. Imaging labs, pharmacy, and the quiet killer, observation. Protocols drift towards serial troponins, D-dimers, and CT to rule out. Each line is billable. Cross a time threshold and you're placed in observation, technically outpatient, with different cost sharing. A migraine that could have been treated, observed briefly, and discharged becomes an overnight OBS stay with repeat labs and monitoring. Your guardrail. In the room, ask, what are we ruling out, and how would a normal result change the plan? Confirm status. Am I inpatient or observation? Pin criteria and recheck time. Prompt discharge when goals are met. Lever 5, the outsourcing margin. The management services organization takes a slice, percentage of collections, performance bonuses, tech, scheduling, and coding fees. To make the margin, staffing grids tighten, RVU targets rise, and mid-levels carry more volume under protocols. Fewer attending physicians per shift means longer waits and shorter visits. Throughput rises, time for thinking shrinks. Your lever. Aim complaints at the right layer, MSO leadership for coding patterns, hospital compliance for facility levels, and state boards if branding confuses who's billing. Name owners in writing. Opacity is their shield. Lever 6. Deny, delay, and rebill. Claims are engineered to withstand denials with front-end scrubbing and precise modifiers. When payers still deny, the group rebills with alternatives that preserve higher payment than the original lower level. Arbitration is used surgically. Cherry-pick winnable cases, bundle similar claims, file where outcomes trend higher, and slow-walk disputes to force interim payments. Every friction point is monetized. Your defense. Keep deadlines tight. Respond within appeal windows, attach exhibits, and escalate to your regulator or the federal portal when protections apply. Set your clock. Day 14 insurer appeal, Day 30 provider dispute, Day 60 regulator escalation. Lever 7. Post-NSA arbitration and loopholes. With most emergency balance billing banned for patients, the target became the arbitration benchmark. That means curating high comparables, leaning on charge data, and routing eligible claims into independent dispute resolution where awards can exceed median in-network rates. Gaps persist. Ground ambulances often sit outside federal protections. Post-stabilization consent can flip protections. Facility fee oversight is thin. The principle holds: shift fights into forums that clear higher prices, then spread the cost across premiums. Your move: cite the law in writing if you're billed improperly, copy your insurer, and insist on in-network cost sharing for emergency professional claims. If uninsured, use the good faith estimate dispute when the overage exceeds $400 for that provider. Spot early flags, sprawling templated histories, CT to be safe, with a low-risk story, observation with minimal changes in care, and multiple logos on discharge papers. You won't stop every lever in the room, but you can build the record to knock them down later, turning a four-figure shock into a controlled, defensible bill. How care gets worse: staffing, wait times, and quiet closures. Here's where the billing machine bleeds into outcomes. When debt sets the tempo, care bends around the spreadsheet. You feel it before you see a clinician. Fewer names on the whiteboard, triage stacked, and a waiting room that barely moves. The scoreboard isn't problem solved. It's throughput hit. Clinician mix matters. PAs and NPs are vital, but not as physician replacements under RVU pressure. When mid-levels are stretched to cover complex cases and coached to document extensive, nuance disappears. Borderline chest pain becomes a checkbox recipe. Subtle neuro changes get lost in flow sheets. You go home with return if worse, and you come back worse. A microstory from Dallas. Jason, 42, arrived with vague chest tightness. Vitals normal, risk low. The attending covered 2 pods. A PA ran point with a checklist. D-dimer, troponin, CT to rule out. 7 hours later, discharged with GERD meds. 2 days after, he returned in ventricular tachycardia. He survived. The first visit optimized documentation. The second visit saved his life. Everything changes when the clock becomes the KPI. Length of stay targets sound benign. Don't clog beds. Under revenue heat, they become a hammer. Treat the symptom, discharge early, avoid admissions that trigger denials. Dashboards look cleaner. Bouncebacks climb. You won't see that on an investor deck. You'll see it at 3 a.m. when the same faces reappear sicker. Boarding is the hidden cue that breaks safety. Inpatient beds jam, so admitted patients live in the ER for hours or days. Rooms are blocked. Care spills into hallways. Hallway care is no care. No monitors, no privacy, diffuse ownership. Small problems grow. Pressure ulcers start in chairs. Antibiotics delay because not my patient yet. When real trauma hits, pivot capacity is already spent. A charge nurse in Michigan told me, "We boarded 14 last Tuesday. A frail COPD patient desatted in a hallway while I hunted for a portable monitor. We stabilized him, but that should never happen. We're running a hospital in the lobby." That's the quiet indictment of a debt-timed system. Staffing grids reflect balance sheets, not acuity. One fewer attending overnight, one tech floated to CT, one scribe covering 2 pods. On paper, it looks similar. At the bedside, every missing hand compounds delay. Door-to-dock stretches, left without being seen ticks up, and risk hides between timestamps. Good clinicians leave. Locums plug holes at a premium. Continuity evaporates. Clinician burnout is the fuse. Do more with less. Hit RVUs. Chart to the template. Reconcile denials. Repeat. A veteran ER doctor in Arizona said, "I still love the medicine. I hate the metrics. The worst day isn't a tough save. It's the day the spreadsheet wins." When experience exits, outcomes follow. You might ask, if the money's this rich, why do hospitals close? Because the money doesn't stay with the hospital. PE-backed slices, ER staffing, anesthesia, radiology, negotiate uplifts and guard margins. The facility holds EMTLA, standby capacity, and fixed costs. Arbitration wins on professional claims don't pay for an ICU nurse at 2 a.m. cross-subsidies crack. Math breaks first where buffers are thin. Rural and safety net ERs are the early alarms. In one Georgia county, anesthesia flipped to a PE group, rates spiked, and the hospital walked away from nighttime surgical coverage. Transfers surged. The ER became stabilize and ship. A year later, it reopened as a freestanding ED without inpatient beds. Ambulances now drive 40 minutes for admissions. Door-to-needle times stretched. Stroke outcomes worsened. Control without buildings makes it worse. When a staffing firm covers most ERs in a metro, payers can't steer. Contract breaks push groups out of network or into arbitration. The price floor rises. Patients don't witness the spat. They feel it in premiums, deductibles, and narrower networks that trap them in slower care. Another microstory, Mia, 7, arrived to a thin night shift with fever and lethargy. Triage flagged sepsis risk, but labs lagged behind a CTQ. 2 hours later, antibiotics started. She recovered, but her mom's question stung. "If you had one more nurse, would this have been faster?" The nurse nodded. And here's the human breaking point. Dr. Jennifer Martinez, an ER physician in rural Oklahoma, worked under a team health contract that demanded 4.2 RVUs per hour, about a patient every 14 minutes. She charted in hallways, ordered defensive CTs, and discharged early to hit length of stay targets. After 18 months, she left for urgent care. Her hospital went on divert, then lost overnight coverage. Within weeks, transfers doubled. Within months, the board paused the ER at night. Jennifer told me, "I didn't leave medicine. Medicine left me." So what do you do inside this pressure cooker? Treat slow care as a signal, not an annoyance. If you're stable, escalate politely. Charge nurse, please. These are our red flag symptoms. Ask who owns each task. Who's ordering antibiotics? Who's reading the film? What time is reassessment? Names and times turn into leverage if you bounce back, or if the bill inflates. Anchor decisions to actions. What are we ruling out? If normal, what changes? That cuts low-yield tests and documents necessity when they proceed. If observation floats, pin status, criteria, and recheck time. When goals are met, request discharge. Every hour shaved is charges avoided and hallway risk reduced. Plan routes now. If your closest ER is often on divert, pick a backup. Star 2 in-network urgent cares with X-ray and weekend hours for gray zone problems. For kids, memorize the nearest pediatric-capable ER. Minutes matter for stroke, sepsis, trauma, and for avoiding the slow spiral debt-timed staffing creates. Finally, watch the failure tells. Rising left without being seen, frequent boarding, quiet pauses in OB or psych, and rotating staffing logos on badges. Those are early cracks. When you see them, tighten your plan and widen your alternatives. Care gets worse when extraction outruns mission. Your defense is preparation in calm moments and precision in chaotic ones. A patient walks in. the wallet timeline from triage to collections. You step through sliding doors and, without realizing it, step into a financial workflow. Intake hands you a tablet bundling 3 consents: treatment, billing permission, and, after stabilization, consent to out-of-network services. Keep it short and surgical. I consent to emergency care. I don't consent to non-emergency out-of-network services without my approval. Then ask, who employs the ER clinician here, and are they in my network? Write the legal entity, not the brand. Photograph the consent screen and your wristband. Those images become leverage when the coding starts to morph your visit into revenue. Triage is quick, but it seeds the ER facility level. The nurse documents resources used that later justify level 3, 4, or 5. Help yourself clinically and financially by being precise. Anchor onset and negatives. Started at 7 p.m., no chest pain, no shortness of breath, no neuro changes. Appoint a quiet note taker. Names, timestamps, orders placed, and reassessment promises. That log shrinks low-value tests and clips the excuses used to bump the facility level. Orders are the first fork. Protocols drift toward rule-out cascades because they're defensible and billable. When you hear, let's get a CT to be safe, deploy 3 calm questions. What are we ruling out? If normal, how does it change the plan? Is there a lower radiation or lower cost alternative? If the answer is clinical, we're excluding a bleed. If normal, home. You've documented necessity. If it's vague, you've planted grounds to challenge low-yield ads later. Log every order as it happens. Labs, imaging for meds, monitoring, and start/stop times. Observation is the quiet pivot. Cross time thresholds and you're placed in OBS. Outpatient rules with different cost sharing. Ask directly, am I inpatient or observation? If observation, pin criteria and the clock. What metric are we watching? When is the recheck? And who decides discharge? Confirm milestones. If repeat labs at 10 p.m. are normal, can we discharge then? Every unnecessary hour adds monitoring charges, pharmacy lines, and nudges the ER level upward. Before you leave, lay foundations for the paperwork fight you hope you won't need. Ask for a visit summary listing tests, meds, times, and your discharge diagnosis. Ask which entities will bill you. Hospital legal name, ER physician group legal name, radiology group, lab vendor. Request an itemized bill and the ER level justification be sent when available. That request gets logged. Photograph discharge documents and any signage with billing contacts. If they ask for payment at the desk, say, happy to leave a deposit pending insurer adjudication. Please label it deposit, not paid in full. 1 to 2 weeks later, your explanation of benefits lands. Ignore that this is not a bill font. Scan 5 items. The ER facility level, the clinician's E/M level, any out-of-network flags, how cost sharing was applied, and denials. If an emergency professional claim hit out of network, call your insurer immediately. This was emergency care. Federal protections require in-network cost sharing. Please reprocess. Get a reference number. Write it across the EOB. Now request records. From the hospital, itemized charges with CPT/HCPCS and revenue codes, plus the written policy supporting the assigned ER level. From the physician group, the visit note and the billed E/M code. From radiology, the report and CPT. Compare reality to paperwork. If the chart shows brief monitoring, oral meds, and low complexity, but the facility says level 5, ask for a level review referencing their criteria verbatim. If the E/M looks padded relative to the note, request a clinical review anchored to medical necessity and resource use. Bills arrive next, staggered to fragment your attention. Respond in writing within 30 days. To the hospital, please provide an itemized bill with CPT/HCPCS, revenue codes, and ER level justification per policy. To the physician group, please provide the note and documentation supporting E/M level X. If you see any balance beyond in-network cost sharing for an emergency professional service, send a short No Surprises Act letter and copy your insurer. Emergency professional services require in-network cost sharing. Balance billing is prohibited. Please adjust. Save PDFs and screenshots. Date stamp everything. If an appeal is denied, climb the ladder. Internal appeal first, 2 tight paragraphs plus exhibits. EOB, itemization, leveling policy, visit note, and your reference numbers. If protections apply and the provider persists, file through the federal complaint portal. If protections don't apply, escalate to your state regulator or consumer assistance program. Set your cadence. Day 14 insurer appeal, Day 30 provider dispute, Day 60 regulator escalation. Deadlines move money. Negotiate with anchors, not pleading. Ask nonprofits about financial assistance, even if insured. 4 settlements, pegged to Medicare multiples. I can pay 140% of Medicare for facility, 125% for professional as a prompt pay. If you need a plan, request 0 interest and paid in full upon completion in writing. If a collector surfaces, slow it down. Within 30 days, send a dispute and validation request, itemization, EOBs, and original creditor. Notify the provider the account is under active appeal and request recall. Monitor credit monthly and dispute premature reporting. A quick micro-win proves the path. Kim's 45-minute dehydration visit posted as ER Level 5 with observation status and a Level 4 E/M. We pulled the leveling policy, showed no continuous monitoring, brief nursing intensity, oral meds only, downcoded to Level 3. The observation ad fell for lack of criteria. The E/M dropped after a clinical review. Final out-of-pocket cut by 58%. Same care. Cleaner record. Better math. From doors to collections, inertia extracts by default. Your counter is a COM script. Narrow consent at intake, timestamp orders, PIN status and discharge criteria, capture billing entities, audit codes against documentation, appeal on a clock, and negotiate with benchmarks. Do that, and you stop funding management fees and debt service with your silence. Your dollars pay for care, not the spreadsheet behind it. Meet the middlemen, PE firms, management companies, and shell entities. Let's pull the camera back and meet the people you never see but always pay. Your badge says Metro General. Your professional bill comes from Regional Emergency Physicians, PLLC. The appeal address points to Apex Management Services Organization, LLC. The call center answers, Team Health, how can I help? That layering isn't a mistake. It's a moat. It separates revenue from responsibility and routes your dollars through a maze built to extract and deflect. Here's the skeleton. A private equity fund buys a national staffing platform. Think Team Health under Blackstone or Envision's M-Care arm under KKR before Envision's 2023 bankruptcy. The patient-facing contracts live inside regional professional corporations, owned on paper by physicians to satisfy corporate practice of medicine laws. The operational muscle, billing, coding, credentialing, recruiting, scheduling, and IT, sits in a separate management services organization, or MSO. A marketing affiliate licenses the brand. Real estate is often carved into a leaseback vehicle. Each entity invoices the others. On your EOB, it's a single line. In the ledger, it's fees, interest, and rent flowing up the chain. Why so many boxes? Because extraction hides in the spaces between. The MSO typically takes a percentage of collections, 7% to 15%, plus performance, coding audits, denial management, analytics, and 24/7 scheduling fees. Parents can lend at above-market internal rates, so interest siphons cash before profit exists. Sale-leasebacks turn offices into rent obligations. By the time money reaches the professional corporation that carries malpractice risk and clinician payroll, the margin looks thin enough to demand higher rates, while the upstream books show healthy fees. Debt is the metronome. Leveraged buyouts push interest payments onto the operating company. That's why RVU quotas creep. Mid-levels cover more volume under protocols, and documentation templates swell. After the No Surprises Act closed direct patient balance bills for emergency professional services, strategy shifted to arbitration. Curate high comparables, file where outcomes skew rich, and let MSO analytics target winnable claims. It's not random, it's scripted. Control without title keeps the gears turning. On paper, physicians own the professional corporation. In practice, the MSO controls staffing, budgets, software, and payer strategy through the Master Services Agreement. If doctors push back, the MSO can withhold services. No schedulers, no coders, no IT. Try running an ER contract without those. When you complain to the hospital, they point to the group. Press the group, they point to the MSO. Reach the MSO, and they say they're just a vendor. That triangle is by design. Now tie it to your bill. The hospital facility fee may sit under a nonprofit parent with financial assistance. The ER professional charge comes from a for-profit physician entity at an MSO address states away. Radiology is a separate physician group. Lab, another vendor. If the hospital approves charity care, it doesn't automatically touch the ER doctor's bill because a different owner holds that account. 1 visit, 3 owners, for policies, 5 appeal addresses. Fragmentation raises friction, and friction raises yield. A quick story shows how daylight breaks the loop. A teacher in Ohio sent 3 balances for 1 visit. $6,920 facility under a nonprofit. $1,080 professional from River Valley Emergency Physicians, PLLC, and $420 radiology from Metro Imaging Associates Incorporated. We mapped entities. River Valley was managed by Apex MSO, LLC, a portfolio company of Stonebridge Capital. We asked the MSO for the clause authorizing billing under the hospital brand. Silence. We filed complaints with the state attorney general and the medical board and copied hospital compliance, naming the MSO and its PE parent. 2 weeks later, the physician group offered a 70% reduction. Radiology matched the hospital's charity discount. What changed? The middlemen lost cover. Use that playbook. At intake, map the stack. Who employs the ER clinician? Who manages billing? Who reads imaging? Write legal names. After discharge, demand itemization and ER-level criteria from the hospital. The visit note and build E/M from the physician group. The radiologist's report and CPT. If an emergency professional claim is billed beyond in-network cost sharing, send a No Surprises Act letter and copy your insurer. If the MSO stonewalls, copy hospital compliance and the board. Reputation moves faster than portals. Last piece, ownership transparency. Many states require disclosure of controlling interests. Search, then name them. River Valley Emergency Physicians, managed by Apex MSO, a Stonebridge Capital portfolio company. Put that sentence in your letters. When you show you know the stack behaves. Surprise billing laws. What changed and what didn't? Let's get precise about what the No Surprises Act fixed, and where the bill still hides. For true emergencies, if you're treated by an out-of-network clinician at any hospital, your cost sharing should match your in-network levels. Balance billing for those emergency professional services is largely banned. Air ambulance got protections, too. If you're uninsured or choose to self-pay, you're entitled to a good faith estimate before non-urgent care and a federal dispute path if the final bill exceeds that estimate by more than $400 for a single provider. Those guardrails kicked in during 2022 and pulled a lot of the ugliest shocks out of your mailbox. But the money didn't vanish, it moved. The law created independent dispute resolution, arbitration, between insurers and providers when they can't agree on payment. Patients are mostly out of the middle, which sounds great. Yet arbitration volumes exploded, and awards often land above median in-network rates. Add filing fees, legal prep, and admin churn, and system costs rise. You don't see a line called arbitration surcharge, but you feel it in premiums, narrower networks, and tougher utilization management. KKR and Blackstone-backed groups learned fast. If you can't balance bill the patient, set the benchmark high in a forum that trends higher than contracts. Facility fees are the biggest carve-out. The NSA didn't standardize or cap ER levels. Hospitals assign a level based on resources used and bill a hefty facility charge. Oversight is thin, policies vary by hospital, and audits happen after the fact. That's why a 45-minute visit with oral meds can still post as Level 5 facility on your EOB, even when the professional cost share looks normal. The law shielded you from the clinician ambush. It didn't defuse the facility bomb. Team Health and Envision don't own that line, but their documentation patterns often help justify higher levels. Ground ambulances are another gap. Federal protections excluded them. Some states passed their own rules, many didn't. If your local EMS is out of network, you can still get balance billed unless state law says otherwise. Practical move. Ask your plan which ambulance partners are in network and how emergencies process. Document the emergency on any bill if one lands. Post-stabilization consent is the quiet flip. Once you're medically stable, a hospital or clinician can ask you to consent to out-of-network care. If you sign, federal protections may no longer apply for those services. You can refuse unless delaying care would harm you. Safe script. I decline non-emergency out-of-network services. Please provide an in-network clinician or document unavailability. If no in-network option exists, ask them to note that in the chart with a timestamp and the name of the person informing you. That sentence protects you later when billing starts to wander. Here's how to activate your rights without drama. Start with processing. If your EOB shows an emergency professional claim processed out of network, call your insurer and say, "This was emergency care. Federal protections require in-network cost sharing. Please reprocess." Get a reference number and write it across the EOB. If a provider balance bills you for NSA-covered emergency services, send a brief written dispute, attach the EOB, copy your insurer, and set a timeline. Please adjust within 15 business days. Uninsured or self-pay. Ask for a good faith estimate before non-urgent care. If the final bill exceeds the estimate by more than $400 for that provider, file the federal patient-provider dispute within the window. Attach the estimate, the final bill, and any portal messages. If you're insured and offered a cash discount, compare it to your expected in-network cost share and confirm whether waiving insurance forfeits protections. Don't trade federal rights for a marketing rate. Now the tactics you never see. Staffing firms curate high comparables. Pick venues where arbitrators skew higher, bundle claims to raise stakes, and delay to pressure payers. Insurers counter with narrower networks, stricter prior auth, and denial float, time value of money earned while you wait. Patients are shielded from a single catastrophic shock, but planned friction and monthly costs climb. Documentation is your lever. Post-NSA disputes hinge on the record. Was it an emergency? When were you stable? Did you consent to non-emergency out-of-network services? And what resources justified the facility level? Photograph consent screens, save discharge summaries, and request itemization with the hospital's published ER-level policy early. If the facility level looks high, line up criteria with the chart, monitoring hours, nursing intensity, for meds, procedures, and ask for a level review. If the clinician's E/M looks inflated, request a clinical review anchored to medical necessity and resource use. 2 quick wins prove the path. An out-of-network ER doc balance billed $1,900. We cited the NSA. Attached the EOB, copied the insurer, balance wiped after reprocessing. A level 5 facility for a 40-minute visit with oral meds only. We pulled the leveling policy, showed criteria weren't met, and the hospital downcoded to level 3. The law gave the frame. Your paperwork delivered the proof. Your 3-step ER bill defense plan, actionable. Here's the plan that turns chaos into control. Pre-commit before you ever need the ER, run a tight script during the visit, and audit fast after. Do this and you'll cut exposure by at least half while building a record that wins appeals, without turning a medical scare into months of paperwork. Step 1, pre-commit. Build your route map, now so decisions are automatic under stress. Make 3 lists in your Notes app. Red flag ER, no debate. Stroke signs, face droop, arm weakness, slurred speech. Chest pain with pressure, sweating, or nausea. Severe shortness of breath, uncontrolled bleeding. Head injury with confusion, loss of consciousness, or persistent vomiting. New weakness, seizures, or fainting. Major trauma. Severe abdominal pain with rigidity or high fever. Heavy pregnancy bleeding, anaphylaxis. Chemo fever 100.4 degree F+. Any head hit on blood thinners. Urgent care capable. Simple lacerations, sprains and likely minor fractures for X-ray and splinting. Ear infections. Sore throat needing rapid strep. Pink eye. Mild asthma responsive to inhaler. UTIs, rashes, tick bites. Migraines responsive to usual meds. Telehealth first. Med refills. Sinusitis after 10 days. Stable rashes with photos. Mild GI illness without red flags. Travel meds. Basic mental health follow UPS. Star 2 in-network urgent cares with X-ray, for meds, and weekend hours. Save the nurse line and your Triage app. Test logins. Add an ICE note to your lock screen. Name, allergies, meds, conditions, primary care, insurer and member ID, plus emergency services. Process at in-network cost sharing. No non-emergency out-of-network services without my consent. Do a 5-minute household drill. Who grabs insurance cards, who is the note taker, where you'll go for red flags, and which urgent care is Plan B. Set a 6-month reminder to refresh locations. Step 2, script the room. Your words create the record that drives billing and appeals. Intake. I consent to emergency care. I do not consent to non-emergency out-of-network services without my approval. Ask, who employs the ER clinician here, and are they in my network? Write legal names. Photograph consent screens and your wristband. Triage. Be precise and narrow the differential. Onset time, key symptoms, and notable negatives. Severe ankle pain since 7 p.m. No chest pain, no shortness of breath, no head injury. Appoint a note-taker to log names, timestamps, orders, and reassessment promises. Orders. Use the 3-question script. What are we ruling out? If normal, how does it change the plan? Is there a lower radiation or lower cost alternative? You're not refusing care, you're aligning tests to decisions. Log each order as it happens. Labs, imaging for meds, monitoring, and start/stop times. Status. Observation is the quiet pivot. Ask, am I inpatient or observation? If observation, pin, what criteria are we watching, when's the recheck, and who decides discharge? Confirm the clock and prompt discharge when goals are met. Every extra hour adds monitoring and pharmacy lines and elevates the facility level. Before discharge, ask for the ER facility level assigned and a visit summary listing tests and meds. Request itemization and the legal names of billing entities: hospital, ER physician group, radiology lab. If asked to pay, say, please take a deposit pending insurer adjudication. Label it deposit, not paid in full. Step 3. Audit fast after. Move quickly while systems are still warm. EOB check. When the EOB arrives, scan 5 items: ER facility level, clinician E/M level, out-of-network flags, how cost-sharing was applied, and denials. If an emergency professional claim processed out of network, call to reprocess under federal protections and get a reference number. Records, request immediately. From the hospital, itemize charges with CPT/HCPCS and revenue codes, plus the written ER level criteria. From the physician group, the visit note and billed E/M code. From radiology, report and CPT, compare and challenge. Match charted resources to the facility level, monitoring hours, nursing intensity for meds, procedures. If it doesn't fit, ask for a level review referencing line-by-line policy criteria. If the E/M looks inflated, request a clinical review anchored to medical necessity and resource use. Appeals cadence. Internal appeal first. 2 tight paragraphs plus exhibits. EOB itemization, leveling policy, visit note, reference numbers. Calendar deadlines. Day 14 insurer appeal. Day 30 provider dispute. Day 60 escalation to your state regulator or the federal portal when protections apply. Negotiate with anchors. Ask nonprofits for financial assistance, even if insured. For settlements, pegged to Medicare multiples. I can pay 140% of Medicare for facility, 125% for professional as a prompt pay. Get zero-interest plans with paid in full upon completion in writing. Collections. Within 30 days of first notice, send a validation request. Notify the provider the account is under active appeal and request recall. Monitor credit and dispute premature reporting. Pre-commit now, script the room, audit on a clock. That trio turns billing theater into paperwork you can win and stops a predatory playbook from betting you won't fight back. Avoiding the ER trap, practical alternatives and thresholds. Prevention beats paperwork. Your job isn't to tough it out. It's to route care into the right lane before the ER meter starts ticking. Think of this as tactical placement under stress. Start with urgent care and extended hours clinics. They're not mini hospitals, but they handle more than people think. Good fits. Simple lacerations that need a few stitches or glue, sprains and likely minor fractures they can splint with an on-site x-ray, ear infections, sore throats that need a rapid strep, pink eye, mild asthma flares responsive to an inhaler, UTIs, rashes, tick bites, dental pain triage with antibiotics, simple migraines that respond to usual meds, and quick med refills. Call first and ask 2 questions. Are you in my network? And do you have x-ray for meds or point-of-care labs? Many post flat rates. A $150 to $300 visit plus a $60 x-ray beats a 4-figure ER facility fee every time. Retail clinics, inside pharmacies and big box stores, work best for one-issue, low-complexity visits. Strep, flu, minor rashes, vaccines, blood pressure checks, birth control refills. They won't handle chest pain, shortness of breath, head injuries, dehydration needing IVs, or anything that might require imaging beyond a basic x-ray. Use them early, not after symptoms escalate into ER territory. Telehealth is your fastest filter. A 15-minute video visit can settle conjunctivitis, sinusitis after 10 days, stable rashes with photos, GI upset without red flags, coughs with normal oxygen, travel meds, and mental health refills. Ask for home care plus a safety net list, so you know exactly when to escalate. Many plans route telehealth to in-network clinicians automatically. Employers often cover it at low or no cost. Nurse advice lines are a hidden gem. They use evidence-based protocols to triage and can book same-day urgent care or primary care. Save the number. For a child's fever, new cough, or mild wheeze without distress, they'll ask targeted questions and steer you confidently. That stops the better safe than sorry drift into an avoidable ER bill. Employer or community clinics reach further than you expect. Many handle basic labs and x-rays, common procedures, chronic disease tune UPS, and same-day acute slots. If your employer offers one, enroll and note hours. Because they're prepaid, out-of-pocket is usually low or zero, and they can fast-track to partner urgent cares if you need imaging or meds. Now, the non-negotiables. Call 911 or go straight to the ER4. Stroke signs, face droop, arm weakness, slurred speech, sudden worst-ever headache, chest pain with pressure, sweating, nausea, or pain to arm or jaw, severe shortness of breath, uncontrolled bleeding, head injury with loss of consciousness, confusion, or persistent vomiting, new weakness, seizures, or fainting, major trauma, severe abdominal pain with rigidity or high fever, heavy pregnancy bleeding or severe pain, anaphylaxis, throat swelling, trouble, breathing, any rapidly worsening condition in infants under 3 months. If you're on blood thinners and hit your head, go. If you're on chemo with a 100.4 degrees Fahrenheit fever or higher, go. For mental health crises where safety is at risk, go. Set gray zone thresholds in advance so you're not guessing at midnight. Dehydration from GI illness? Try telehealth for anti-nausea meds and oral rehydration. If you can't keep fluids down after 2 hours, or you're confused or breathing fast, escalate. Urgent care if stable, ER if worsening. Asthma flare? If 2 rounds of a rescue inhaler don't help, or you can't speak in full sentences, ER. Migraine? If your usual regimen fails, or there's worst ever pain or new neurosigns, ER. Otherwise, urgent care can give 4 fluids, antiemetics, and NSAIDs at a fraction of ER cost. Minor fractures? Urgent care for X-ray and splint. If obvious deformity, numbness, and open wound, or uncontrolled pain, ER. Plan routes before you need them. Star 2 in-network urgent cares with X-ray, weekend hours, and online waitlists. At a 24-hour pharmacy. Log into your telehealth app now. Note the nearest ER with stroke and cardiac capability. If the closest facility posts frequent diversion or recently paused services, pick an alternate. For kids, memorize the nearest pediatric-capable urgent care and children's hospital. Build a simple home kit, thermometer, pulse oximeter, oral rehydration packets, acetaminophen and ibuprofen with weight-based dosing, antihistamines, a few sterile dressings, an ACE wrap, a cold pack, rescue inhaler refills, and a printed medication list. The right tool at hand shortens visits and keeps you out of the wrong setting. Lock logistics. Decide who drives, who stays with kids, and who's the note taker. Keep an ICE note on your phone and a wallet card with your intake script. If urgent care recommends the ER, ask why and whether to go by ambulance or car. If car and you're stable, call the nurse line en route to alert the receiving facility when possible. You're not avoiding care. You're choosing the right lane at the right speed. That protects your health, your time, and your wallet without hesitating when seconds truly matter. The behavioral economics of medical debt. Let's talk about why smart people still get trapped by predatory ER bills. In a crisis, your brain hunts for certainty and authority. You say yes to whatever sounds safest. KKR and Blackstone are betting you won't fight back. Your edge isn't willpower. It's tiny scripts that override predictable biases. Start with fear and uncertainty. When you don't know what's wrong, do more feels safe. Under RVU pressure, do more also pays more. Your counter is clarity. Ask, what are we ruling out? If normal, what changes? That forces a decision tree. If a test doesn't change the plan, you've just documented low value, ammunition for downcoding later. Ambiguity plus time pressure unlocks fast signatures. Tablets bundle 3 consents: treat, bill, and, after stabilization, permission for out-of-network services. Your reflexes tap through. Replace it with a 10-second fence. Say, I consent to emergency care. I do not consent to non-emergency out-of-network services without my approval. Calm, specific, documented. Anchoring sets the first number as normal. A $6,000 facility line makes a 30% discount feel generous. Use a stronger anchor, Medicare. I can pay 140% of Medicare for facility, 125% for professional as a prompt pay. It's unemotional, legible to revenue cycle staff, and resets the frame from fantasy charges to rational benchmarks. Present bias kills appeals. You'll do it tomorrow, and windows close. Install a two-step timer. When an EOB lands, spend 5 minutes to circle the ER level, the E/M level, any out-of-network flags, how cost-sharing hit, and denials. Then block 20 minutes within 48 hours to send 3 messages. Itemization with ER-level criteria. Visit note and build E/M. Reprocess request if an emergency professional claim hit out of network. Action triggers action. Loss aversion makes threats expensive. Collectors hint at credit damage. You overpay to avoid pain. Ask fact questions. When can medical debt be reported? Is reporting paused during an active dispute? Please confirm in writing. Most medical debt doesn't hit files for months and cannot report during validated disputes. Facts lower fear, and your payment. Authority bias is real in white coats and letterheads. We'll get a CT. Sometimes essential, sometimes defensive. Your safe reply. What's the 24-hour risk if we wait? Is there a lower radiation alternative? You're asking for probability, not permission. Documented low risk plus a safety plan later helps you knock off low-yield imaging charges. Choice overload breeds paralysis. Multiple portals, codes, and envelopes are designed to stall you. Shrink it to 1 folder and 3 moves. Request itemization and ER-level policy. Request the visit note and build E/M. Submit 1 focused appeal or reprocessing request. Then stop. Stack wins over weeks instead of losing a day to chaos. Shame is expensive. People blame themselves and avoid asking simple questions. Strip emotion from the language. Please reprocess emergency professional services at in-network cost sharing under federal protections. Please review E/M level for medical necessity and resource utilization. This is administration, not apology. Recency bias cements the last number you saw. Replace it with 1 line every time. Pending insurer adjudication. Expected patient responsibility unknown. Say it out loud when you open mail. It blocks panic and keeps you on schedule. Social proof beats willpower. Tell 1 person, I'm sending 2 requests by Friday. Text them when done. If you handle household bills, appoint a backup EOB reader. 2 sets of eyes catch out-of-network flags and upcoded levels faster. Status quo bias keeps you on their defaults. Build your own. Notes app line for intake consent. Save templates for itemization, NSA disputes, and clinical reviews. Calendar timers at day 14, 30, and 60. You won't invent good behavior inside a loud room. You'll run the play you prepared. Microhabits close the loop. Photograph wristbands and consent screens. Log names, titles, and timestamps. Start every call with your name and a reference number. End with, where do I upload documents? And what's the timeline? Paper creates leverage. Leverage moves money. One last bias, sunk cost. After you've paid something, you're tempted to keep paying. Don't. If documentation doesn't support level 5, if E/M is padded, if an emergency professional claim hit out of network, dispute anyway. Insurers and revenue cycles adjust accounts midstream all the time. Your prior payment isn't a conviction, it's a placeholder. The system nudges you to overtest, overpay, and overlook. Your counter is boring power. Precise questions in the room, fast paperwork after, timers that keep you inside windows, and anchors that make numbers rational. Do that, and the same psychology that turns fear into revenue turns your preparation into refunds, and turns a predatory playbook into a solvable admin task. Follow the money. Who profits from your ER visit? Let's trace one ER visit and watch where each dollar actually lands. The sticker prices vary, but the split follows a pattern. The hospital's facility charge, the clinician's professional fee, the management services organization, the MSO, behind that clinician group, lenders and investors upstream, your insurer managing premiums and denial float, And if anything lingers, the collections ecosystem that turns your balance into a product. Start with the facility fee. The hospital assigns an ER level tied to resources used. Monitors, nursing intensity for meds, observation hours, procedures. Your plan has a contracted allowed amount. Maybe the charge master lists $6,000, but the allowed amount is $2,850. The hospital books $2,850, then bills your deductible and coinsurance. If your share is $620 and you pay $300, the remaining $320 becomes a workflow decision. Financial assistance review, a zero-interest plan, early out follow-up through a vendor, or placement with a third-party collector. Even if charity later wipes your portion, that $2,850 becomes a benchmark in the next contract cycle, nudging future premiums and deductibles higher. Now the professional fee, the ER clinician's bill. Suppose the allowed amount on a high-level E/M is $420. It doesn't flow straight to the doctor. First, the MSO schemes a percentage of collections, 7% to 15% is common, plus line items for coding audits, denial management, analytics, scheduling platforms, and software licenses. On $420, the MSOs take might be $50 to $70 before malpractice, benefits, and clinician pay. Multiply across thousands of encounters, and that skim becomes a predictable fee stream protected by long service agreements the hospital can't unwind quickly. Where do those MSO dollars go? Up the capital stack. In a leveraged buyout, the operating company carries the acquisition debt. Your visit services interest. Parents can layer related party loans at above market rates, turn office space into sale leasebacks that create rent obligations, and even extract debt-funded dividends. Cash out today financed by tomorrow's collections. On paper it looks like operations. In practice it's extraction, fees, interest, and rent flowing before a clinician ever touches a chart. Insurers aren't bystanders. They collect premiums, invest float, and target medical loss ratios. When allowed amounts rise, through higher ER levels, arbitration uplifts, or consolidated bargaining by staffing firms, plans respond with premium hikes, narrower networks, tougher prior authorization, and more denials. Denial float matters. Slower adjudication and prolonged appeals let them hold cash longer, earning investment income while disputes churn. You feel it as friction. Their quarterly report records it as yield. If you can't cover your piece, the receivable travels. Some hospitals keep accounts in-house, using early-out vendors to nudge payments. Others sell portfolios for pennies on the dollar, $1.50 for a $1,000 balance. Then the buyer pursues the full $1,000 plus fees. Recover $300, triple the money. Big pools are financed or securitized, turning thousands of small balances into predictable cash flows that trade like bonds. Your migraine bill becomes someone's coupon payment. Credit reporting is a lever, not just a consequence. Medical debt reporting typically lags for months and pauses during validated disputes, but the threat accelerates payments. Collectors lean on loss aversion. This could affect your credit. To push people into overpaying today to avoid a possible hit tomorrow. That behavioral edge is modeled into recovery targets. There's status arbitrage too. Nonprofit hospitals bill commercial rates, stockpile reserves, and keep tax exemption by counting community benefit, sometimes inflated by foregone charges. Meanwhile, private equity-owned physician groups operate as pass-through entities that minimize taxes via interest deductions and LLC structures. Different rules, same patient, coordinated outcome. High prices with low transparency. Follow the split and closures start to make sense even when numbers look big. Profitable slices, ER staffing, anesthesia, imaging, sit in separate entities. They negotiate uplifts, guard margins via arbitration, and pass costs through. The hospital holds EMTALA, the lights, standby ICU capacity, and uninsured care. As slices extract more, cross-subsidies that kept the trauma bay ready thin out. Add labor inflation and higher interest, and the math snaps first in rural and safety net facilities. So where do you aim for impact? First, the hospital facility line is usually the largest and most flexible, secure financial assistance there. Then pressure the clinician group to match the hospital's discount. Name the MSO and its private equity owner in writing and copy hospital compliance. For emergency professional claims, enforce No Surprises Act cost sharing so you're not personally funding arbitration premiums. If a collector appears, negotiate with Medicare-anchored offers. 140% for facility, 125% for professional. They likely bought low, so you can settle low. And keep your paper tight. Itemization, ER level criteria, visit notes, EOBs, reference numbers. Paper moves money. A microproof. Lauren's ankle sprain produced 3 bills. $2,230 facility at level 4. $410 professional at E/M level 4. $180 radiology red. We pulled the leveling policy. Brief monitoring. No 4 meds, simple splint. Criteria matched level 3. Downcoded. The visit note supported level 3 E/M, not level 4. Clinical review cut it. Radiology matched the hospital's charity percentage after we named the MSO and copied compliance. Out of pocket fell 61%. Same ankle. Cleaner record. Better math. When you see the flow, you stop funding upstream fees with downstream silence. That's how more of your dollars stay local. Paying for care you received, not interest and management contracts you never agreed to. Why hospitals close while costs rise? If money's flying around the ER, why do hospitals still go dark? Start with rate shocks. In the 201s, systems borrowed at floating rates to expand, upgrade IT, and survive the pandemic. When rates climbed, interest expense spiked, covenants tightened, and cash got rationed. You can freeze hiring and delay capital, but you can't refinance a nursing shortage. That buys quarters, not stability. Next, cross-subsidies cracked. For decades, profitable lines, elective ortho, cath labs, outpatient imaging, quietly funded always-on capacity. ER, OB, ICU, psych. Then private equity, backed in corporate groups, peeled off the profit slices into ambulatory centers with lower overhead and stronger rate leverage. The 10 a.m. knee scopes that subsidized the 3 a.m. trauma bay moved across town. Hospitals kept EMTALA and standby teams while the margin that paid for them walked. Payer mix drift piled on. Medicaid redeterminations pushed patients off coverage. High-deductible plans turned insured into self-pay after insurance, the hardest dollar to collect. Bad debt rose while Medicare updates lagged wage and supply inflation. Revenue softened, costs hardened. You might think post-No Surprises Act arbitration windfalls offset the gap. They don't for hospitals. Uplifts mainly land on professional claims billed by outsourced groups, not the facility ledger. The hospital's own facility fee sits under multi-year contracts, denials, and audits. It looks big on a charge master. It lands smaller later and with more work. Labor costs reset higher and stayed there. Burnout pushed nurses out. Travel staff filled gaps at premiums. Even after rates cooled, wage floors didn't. Leaner grids raised left without being seen and boarding times, which dragged throughput and reimbursement. Thin teams chart less completely, triggering denials that stall cash. It's a negative flywheel. Fewer people, slower care, weaker revenue, tighter cash. Real estate maneuvers added drag. Sale-leasebacks freed cash once, then locked in long-term rent. Stack lease payments on bond debt and IT amortization, and your fixed costs climb while profitable volume erodes. Insurer strategy compounds it. To counter higher allowed amounts elsewhere, plans narrow networks, harden medical necessity, and stretch prior auth. Hospitals wait longer for approvals, spend more on admin, and eat higher denial rates. Meanwhile, denial float earns insurers while you wait. For patients, it's friction. For insurers, it's yield. Ownership fragmentation misaligns incentives. ER staffing, anesthesia, radiology, hospitalists. Each sits in a separate profit center with investor timelines. They negotiate hard, guard margins with arbitration, and pass costs through. The hospital holds the lights, ICU standby, and unfunded care. As every slice protects itself, the core loses flexibility to cross-subsidize, and boards face 4 doors. Cut services, convert to freestanding ED, sell, or close. A microstory shows the spiral. Pine Ridge County's community hospital lost its independent anesthesia group. Coverage flipped to a PE-backed firm. Rates spiked. The hospital dropped 24/7 surgical coverage. ER transfers surged, admissions fell. With travel nurse spend high and denials rising, the board paused overnight ER staffing, then converted to a freestanding ED. Now ambulances drive 38 minutes for inpatients. Door-to-needle times stretched. Stroke outcomes worsened. The debt service didn't shrink, capacity did. Get efficient has limits. Many have tried, lean pathways, bed huddles, hospital at home, discharge command centers. But physics is stubborn. You can't run an ICU at half a nurse per patient. You can't keep a cath lab available without cardiologists on call. And you can't staff to real ER demand if the profitable daytime cases that subsidized nights were siphoned away. Control without buildings makes it harsher. When a staffing firm covers most ERs in a metro, payers can't steer. Contract breaks push groups out of network or into arbitration. The price floor rises, premiums climb, and the hospitals still can't afford a third-night RN. Patients don't see the brinkmanship, they sit in it. What's actionable for you? Watch local stress signals, frequent diversion, rising boarding, OB or psych pauses, rotating outsourced logos, and leadership citing strategic alternatives. Pre-plan alternates for time-sensitive care and 2 in-network urgent cares for gray zones. When you haggle your own bills, secure hospital financial assistance first. The facility line is biggest and most flexible, then push clinician groups to match. If a closure looms, show up early. Ask if management fees ride on collections, whether arbitration strategies are inflating local premiums, and what staffing ratios the board actually funds at night. Public pressure moves faster before the lights dim. Closures don't mean the money vanished, it moved. Profits concentrate in carved-out slices and arbitration wins, while hospitals carry standby care. Until incentives realign, global budgets for capacity, transparent ownership, and caps that stop arbitration from setting the floor. Expect more temporary pauses that quietly become permanent. What better looks like? Models that actually work. Let's flip from defense to design. Faster care, fair prices, and sane staffing show up when money and mission point the same way. None of this is theory. We've seen it work when leaders stop chasing arbitrage and start funding capacity. Start with who employs clinicians. When a hospital directly employs emergency physicians or partners with a physician-owned practice on a fixed-fee, performance-tied contract, RVU pressure eases and documentation reflects reality, not templates. The contract is boring by design, guaranteed baseline coverage by volume band, a set stipend for overnight standby, and bonuses tied to patient-centered metrics. Publish the scoreboard where it matters. Time to antibiotics and sepsis, door to needle and stroke, 72-hour return rates by acuity, and teach back comprehension at discharge. When pay follows outcomes instead of charge intensity, clinicians stay, burnout drops, and bounce-backs fall. Scale the back office cooperatively, not with debt. Independent groups can share billing, credentialing, revenue cycle, and analytics in a physician-owned management entity with guardrails. Fixed fee instead of percentage of collections, open books, no debt-funded dividends, member votes on payer strategy, and external audits that compare codes to resources used. You get data and negotiating leverage without ceding control to an MSO whose bonus rises with code creep. Cleaner claims mean fewer denials and faster cash, which funds staffing instead of interest. Fund standby capacity with predictable top lines. Global hospital budgets. Maryland is the cleanest example. Pay hospitals a fixed, annually adjusted amount tied to population needs and quality. That flips the incentive from bill more to need less. The budget funds the unprofitable but vital parts of care. Surge staffing, a second triage nurse at peak, extra telemetry beds when flu hits. It also pays for upstream fixes that shrink avoidable ER load. Same-day primary care access, paramedic home visits for CHF and COPD, and nurse navigators who close follow-up gaps. When revenue doesn't depend on piling on level 5S, the right number of people show up for the worst nights. Put a 24/7 urgent care lane next to triage. Physically adjacent, clinically supervised by an emergency physician, equipped with X-ray, for meds, and point-of-care labs. At the door, a triage RN and the attending route stable sore throats, simple lacerations, sprains, migraines, and straightforward UT ice into that lane with posted flat prices. Red flags go to the bay. Left without being seen drops because the low acuity queue moves. Door-to-dock tightens for everyone. A sore throat stops inheriting the trauma bays overhead, and the hospital posts a small but real win. Lower total spend with better experience. Make price posting real, not a 500-row CSV no one can read. Publish a one-page grid. Commercial caps for ER levels 1 to 3, Medicare multiples for levels 4 to 5, and the written criteria your hospital uses to assign each level. Add 2 promises. A 10 business day correction if the bill doesn't match policy, and a patient ombuds office with authority to zero obvious errors immediately. When prices are legible and corrections are fast, billing becomes a service, not a weapon. Shine light on ownership and debt. Require any entity that bills under your brand to disclose beneficial owners, outstanding debt, related party agreements, and any percentage of collections fees. If there's a sale-leaseback on clinical space, publish rent and term. If a billing vendor earns performance bonuses for higher code intensity, say it. Transparency changes behavior. It's hard to defend extraction, you have to explain. Lock staffing guardrails to patient. Safety, not spreadsheets. Minimum attending coverage by true volume band. Caps on mid-level to physician ratios, and protected decompression time after high acuity runs. Track 4 measures in public. Sepsis antibiotics within an hour, door to needle and stroke, 72-hour returns by acuity, and left without being seen. Tie leadership bonuses to trends on that board, not revenue per visit. When executives earn more for fewer bounce backs, they fund the extra night nurse. Close legal gaps that invite games. Extend emergency balance billing protections to ground ambulances. Make post-stabilization consent real, written, time-stamped, with in-network unavailability documented. Cap arbitration awards at a reasonable multiple of median in-network rates to avoid ratcheting the benchmark. Require nonprofit financial assistance to auto-apply to co-billed professional charges under the same brand so patients aren't ping-ponged between owners. Let employers accelerate the shift. Self-funded purchasers can set reference prices. Say, 140% of Medicare for low-acuity ER facility fees, and direct contract for after-hours urgent care, same-day imaging, and teletriage. Issue a single access card with routes and known prices. Insist plans auto-route emergency professional claims to in-network cost sharing and fix errors without member fights. When purchasers align around clear anchors, providers adapt fast. Bring care to people who otherwise board. Fund community paramedicine for frequent flyers, mobile crisis teams for behavioral health, and guaranteed 48-hour primary care follow-up blocks for ER discharges. Each reduces hallway risk, readmissions, and length of stay pressure without a new device or buzzword, just aligned budgets and accountability. Proof beats promises. A county hospital replaced a PE-backed staffing contract with hospital-employed ER physicians, stood up a 7 p.m. to 11 p.m. urgent care lane beside Triage, posted prices with a cap on level 3, and published its leveling policy. In 6 months, left without being seen down 1/3, average low-acuity facility levels fell, bounce-backs nudged down, and clinician turnover stabilized. Revenue didn't collapse, denials did. Collections improved because documentation matched reality. This isn't utopia. It's alignment, employment or physician-owned contracts with outcome-tied pay, cooperative scale without debt, global budgets to fund standby capacity, visible prices with teeth, employer coalitions setting fair anchors, legal gaps closed, and public metrics that matter. When the scoreboard measures care, not code intensity, ERs get faster, bills get saner, and trust begins to return. The playbook to share, family, friends, and HR. Knowledge only helps if it travels. Build a one-page wallet card now. Top line: I consent to emergency care. I do not consent to non-emergency out-of-network services without my approval. Add your name, allergies, meds, conditions, insurer, member ID, and primary care. List 2 in-network urgent cares with hours and phone numbers, your nurse line, and your telehealth app login reminder. Add a checkbox trio, request itemized bill, note ER level, capture legal names of billing entities. Screenshot it to your lock screen. Do a 5-minute household drill at dinner. Who grabs insurance cards? Who's the note taker? Which urgent care is Plan A, which is Plan B? For elders, place a second card in the wallet and tape one to the fridge with a current medication list. For teens, paste the intake line in their notes app and pin the nurse line. Role play once so it's automatic under stress. Create a fridge magnet with red flags and green routes. Red flags: stroke signs, chest pain with sweating or nausea, severe shortness of breath, uncontrolled bleeding, head injury with confusion or persistent vomiting, new weakness, seizures, major trauma, severe abdominal pain with rigidity or fever, heavy pregnancy bleeding, anaphylaxis, chemo fever 100.4 degree F+, head hit on blood thinners. Green routes: urgent care for stitches, sprains, UTIs, ear infections. Telehealth for refills, sinusitis after 10 days, stable rashes. Build the documentation habit. Keep a glovebox notebook and a small go bag with chargers, spare glasses, a med list, and snacks. Assign someone to log names, times, orders, reassessment promises, and discharge criteria. Photograph wristbands, consent screens, posted patient rights, and billing contacts. Those pictures become leverage when the EOB arrives. Share 3 negotiation templates in a family note. Itemization. Please provide an itemized bill with CPT/HCPCS, revenue codes, ER level criteria, and NPI. NSA dispute. Emergency professional services must be processed at in-network cost sharing. Balance billing is prohibited under the No Surprises Act. Please adjust. Clinical review. Please review E/M level for medical necessity and resource utilization. Documentation does not support level X. Now take this to work. HR holds real levers. Ask for a 30-minute, avoiding $4,000 ER bills lunch and learn. Show the wallet card, your urgent care map, the nurse line, and teletriage access. Then request 3 upgrades. A 24/7 teletriage that can book same-day urgent care and flag true emergencies. Posted direct pay rates for local urgent care, after-hours clinics, and imaging with a simple employee guide. An ER Shield policy. All emergency professional claims auto-processed at in-network cost sharing with a dedicated escalation contact. Push for reference pricing. If your company is self-funded, the Benefits Committee can cap low-acuity ER facility fees at a fair multiple of Medicare and steer after-hours care to contracted clinics with guaranteed slots. If fully insured, they can still set incentives. Dollar telehealth, low urgent care copays, and a concierge line to route care. Make navigation easy. Ask HR to publish a 1-page sick after-hours guide with QR codes to in-network urgent cares, average prices, and online waitlists. Add the plan's emergency protections language. Emergency professional services process at in-network cost sharing. Include 1 email for appeals help and a direct line for claims corrections. Coordinate locally. Employer coalitions can sign simple MOUs with urgent cares and imaging centers for same-day access, posted cash rates, and reserved after-hours capacity. That takes pressure off ERs and gives employees predictable options. Prove it works. A mid-sized Minnesota manufacturer capped level 1 to 3 ER facility fees at 130% of Medicare, added 24/7 teletriage, and published a 1-page routing guide. In 12 months, ER visits down 18%, claims denials down 22%, average time to care down 27 minutes, and turnover at the partner hospital eased as disputes fell. Savings funded on-site nurse hours and guaranteed urgent care slots. That's what alignment looks like. Set a 30-day audit ritual. Calendar a monthly 30-minute block. Open EOBs, request itemization and notes for any ER visit, file 1 appeal if needed, and log outcomes. Track wins, corrected cost sharing, downcoded levels, charity approvals, and share anonymized results with your team. It normalizes action and kills shame. Pre-pack your digital kit, a shared medical, year folder with EOBs, itemized bills, appeals, outcomes, saved contacts for insurer appeals, hospital billing, physician group billing, and your state regulator. An email rule that tags EOB, statement, or billing into a medical action folder. Default to action within 48 hours. When chaos hits, your playbook runs itself. The biggest mistake to avoid, and your next move. The costliest mistake isn't a level 5 code, a padded E/M, or an arbitration trick. It's silence, letting deadlines pass while portals pile up. Every quiet week hands leverage to someone else. After 14 days, insurer notes harden. After 30, discounts shrink and accounts slide into collections workflows. After 60 to 90, you're fighting timely filing and closed period excuses. Silence turns a $900 error into a $3,200 plan you slowly pay off. KKR and Blackstone are betting you won't fight back. Prove them wrong by running a clock, not a rant. Start the 48-hour routine the moment anything labeled EOB, statement, or bill lands. Step 1. Open Scan Circle. ER facility level, clinician E/M level, any out-of-network flag, how cost sharing was applied and denials. Step 2. Send 3 messages within 48 hours. Itemize bill with ER level criteria to the hospital. Visit note and build E/M to the clinician group. Reprocessing request to the insurer if an emergency professional claim hit out of network. Step 3. Calendar 3 dates. Day 14 for insurer appeal. Day 30 for provider dispute or no surprises act letter. Day 60 for escalation to your state regulator or the federal portal if protections apply. That cadence keeps you inside Windows and puts the burden back on their workflows. Waiting on records? File a placeholder dispute so their clock pauses. Short and sterile works. I dispute line items pending documentation. Please toll deadlines and note active appeal. Attach your record requests and the insurer reference number. Now your paper trail preserves rights if the hospital or the MSO drags its feet. Run the call sequence that moves money. First call, insurer claims. This was emergency care. Professional claims must process at in-network cost sharing under federal protections. Please reprocess. May I have a reference number? Second, hospital billing. Please send itemized charges with CPT/HCPCS and the written policy supporting the assigned ER level. Third, physician group or MSO. Please provide the visit note supporting the billed E/M. If unsupported, I'll request a clinical review. Same day, put each call in writing, 3 concise portal messages with attachments. When denials hit, escalate narrowly. Internal appeal in 2 tight paragraphs plus exhibits. Lead with the rule, then the proof. Emergency professional claim processed out of network. Federal law requires in-network cost sharing. EOB attached. Or, facility billed level 5. Policy requires continuous monitoring and high nursing intensity. Chart shows brief monitoring and oral meds. Adjust to level 3. Ask for a written determination and a timeline. If an NSA-covered emergency still gets balance billed, send a short dispute and copy your insurer. Balance billing is prohibited for emergency professional services. Please adjust to in-network cost sharing within 15 days. They know the rule. You're showing you'll enforce it. If collections appear, it's not over. Within 30 days of first notice, send a validation request. Under the Fair Debt Collection Practices Act, please validate the debt, including itemization, EOBs, and original creditor. This account is under active appeal. Please cease reporting. Ask the provider to recall the debt during adjudication. Many will. Regulator complaints tied to third-party collectors create headaches they avoid. Set your settlement floor now, not when you're exhausted. Decide the maximum Medicare multiple you'll pay. Say 140% for facility, 125% for professional, as a lump sum. When negotiating, state your number once and stop talking. Silence works on your side too. Automate the admin so the system can't win on inertia. Create an email rule that funnels EOB, statement, or billing into a medical action folder. Add a recurring 30-minute block. EOB audit and appeal. Keep one running note with reference numbers, names, and dates. Start every call with your name and a reference number. End with, where do I upload documents and what's the timeline? That's how you turn a noisy, emotional problem into a repeatable process. Your next move is simple. Build the wallet card, star 2 urgent cares, paste 3 templates, itemization, NSA dispute, clinical review, into your notes and block 20 minutes within 48 hours to finish your ER kit. Small prep beats big bills. Silence is expensive. A clock is free. Here's the one thing to remember. ER bills are timed negotiations. Fast, documented moves beat inflated codes, padded facility levels, and arbitration spillover designed to outlast you. Share this with whoever handles benefits at home and send it to your HR team today. Ask them to cap low-acuity ER fees, publish urgent care routes, and auto-protect emergency professional claims. Then watch the next video where I walk live appeals with exact scripts you can copy.